Go ahead, Pia.
Great, thank you. Good evening, everybody. Thank you for joining us tonight. Today, we bring to you two wonderful speakers, Chris Longhurst and Meg Dorsey, who will talk to us today about the nuts and bolts of COVID vaccines and how to get shots into your arms, in your patient's arms. So this is program 4 of our COVID conversations. Next slide, please. Just a couple of housekeeping things. All lines are automatically muted for the duration of the talk. There is a question and answer box. Should be on the right of your screen that you can use to communicate with the moderators. So if you have any questions, please go ahead and put them there. Each panelist will speak for about 15 minutes, followed by questions, and the webinar will be recorded and posted to the California Immunization Coalition website, as well as the CIC YouTube page. Next slide, please. Again, you're in listen-only mode, and you could see what the questions panel looks like there. Again, please go ahead and type in any questions as they come up. If you have any questions afterwards, please email us at info@immunizeca.org for additional responses. The California Immunization Coalition is a 501c3 nonprofit private-public partnership that's dedicated to achieving and maintaining full immunization protection for all Californians to promote health and prevent serious illness, disability, and death. And we are in partnership with the American Academy of Pediatrics-California chapters, who is committed to the attainment of optimal physical, mental, and social health and well-being for infants, children, adolescents, and young adults living in California. So I maybe didn't introduce myself. I'm Pia Pannaraj from Children's Hospital Los Angeles. And then we also have Dr. Eric Ball from Children's Orange County Primary Care Network, and we will be your moderators tonight. So, and from here, I will throw it over to Eric to introduce Dr. Longhurst.
Thanks so much, Pia. I have the distinct honor and privilege of introducing my friend and colleague, Dr. Christopher Longhurst. So Chris is the Chief Information Officer and Associate Chief Medical Officer for Quality and Safety at UCSD. And he provides leadership in areas including continuous improvement, as well as operations for UC San Diego Health. As a CIO, he also oversees all operations and strategic planning for information and communications technology. He went to college at UCSD as well. He has a medical degree from UC Davis, and he completed his residency with me at Stanford Medical School, where he was 1 year ahead of me and taught me everything I know. So I would like to thank Chris for being a good mentor, and I will turn it over to him to talk about their experiences at UCSD with COVID vaccines. Thanks, Chris.
Well, Eric, thanks so much for having me on the webinar this evening. It's really an honor to be invited to share some of the work that we've been up to. And it was a privilege to train with Dr. Ball, who I also learned a lot from. So once somebody gives me the ability to share my screen, I will make sure that I do so. There we go. And there it is. So I am pretty active on Twitter. That's a good way to reach me, share any feedback at CA Longhurst there. You can also email me with any questions after this. I've been at UC San Diego for about 5 years after spending 15 years at Lucille Packard Children's Hospital. And San Diego's been a fun place to help to lead as a member of the executive team. It's a large medical center with about 9,000 employees and 2 hospitals, and we now have a School of Medicine, School of Public Health, and a School of Pharmacy. And then importantly for this talk, we've been using an electronic health record from Epic for the last 10 years or so. So can you guys still see my screen?
Yes.
Looks like great.
But you got out of presenting.
There we go.
There you go.
So one of the things that made UC San Diego really unique during this pandemic, which we've all been living through for the last year, is that it's actually month 13 for us. So February 10th was when the second plane landed from Wuhan, China, with expatriates who were being evacuated. And that plane landed at Miramar here in San Diego. And the first evacuee tested positive here in San Diego and was subsequently hospitalized at UC San Diego. And that was really a blessing in disguise for us. Unfortunately, the patient did great, but it really forced us to develop our processes, our policies, and our workflows around COVID. And so as a result of a lot of very early work, we opened our command center like February 7th, when we heard that the evacuees would be coming to town. And we put a lot of resources, time, and effort into optimizing our electronic health record to make sure that we could support pandemic care. And so this was actually the first publication in the world about EHR optimization to address COVID-19 issues. And there's a QR code there if you want to look at it in more detail. Of course, some of it's out of date now, but it included things like our telehealth efforts, analytics efforts, and even some of the prep work that we were doing early on in anticipation of things like exposure notification systems and vaccination. So this, you can see, was submitted March 18th and published on March 19th. So just a few days after the federal declaration of a pandemic. Now, UC San Diego is part of the University of California health system. So there's 5 medical centers, including San Diego, Irvine, Davis, Los Angeles, and San Francisco. And one of the things that attracted me to UC San Diego was the work that we were doing with Dr. Atul Bue, pediatric endocrinologist at UCSF, to aggregate our data across the 5 medical centers. So collectively, we probably care for about 10% of Californians. And on a daily basis, you can see we get reports like this on the number of tests that are being performed at each site. Now, with a little bit of pride, I share that the orange is UC San Diego. And that really reflects a couple things. One is that our lab was really on top of testing and scaled very quickly. And as a result, we were offering open to the public testing in San Diego County very early on. We've also partnered with a number of elementary schools locally to provide testing, including my kid's own school, which allowed it to reopen last August, which has been a blessing. The second thing that's reflected in that data there is what we call the Return to Learn program. So at UC San Diego, our chancellor bravely invited 10,000 college students back onto campus last fall. And that was after a pilot of the Return to Learn program in the spring showed that we could do self-testing effectively and get results back to students within 24 hours. We held 600 apartments for quarantine purposes. So we actually had more students and employees on campus than any other university in the state. And we kept our rates below 1% throughout this pandemic, which was really a pretty incredible accomplishment. A lot of teamwork went into that. And the testing was no small part of that. However, another big part of that was the exposure notification system. So here in this graphic, you see the Swiss cheese model stolen straight from our Return to Learn website, where the first 3 portions of keeping the campus safe was obviously wearing a face mask, physically distancing, and frequent hand washing. But the 4th and the 5th were frequent symptom screening, and at first it was twice monthly and then weekly testing. And then the 2nd was adding CA Notify to your phone. And that's because last summer we got involved with some advocacy to bring exposure notification systems to the state of California. And the state finally relented our constant pestering and allowed UC San Diego to conduct the first pilot in the state last September, concomitant with moving all of these students back onto campus. So that's been a really interesting experience. We had a 10-week pilot and learned a lot of lessons. UC San Diego, my team actually led the expansion of the CA Notify program to 6 other UCs across the state. And December 7th, the governor announced that this was going to be available statewide. Hopefully many of you on the call are using this today. And in fact, because of our experience expanding this to other campuses, we ended up with a contract to help support the California Department of Public Health and the California Department of Technology with this system. In fact, we just had our weekly huddle today, and we're still working on continuous improvement around optimizing it. But our early data is clearly showing, like the United Kingdom, that this has helped prevent a number of infections. And we saw that anecdotally in our pilot at UC San Diego, where we would have students receive anonymous exposure notifications, quarantine appropriately, test, and on occasion come back positive, before they could spread it to others. So this has been a really interesting experience. And of course, in January, this is sort of capped off with the opening of the first vaccine superstation in the state of California. So I want to talk a little bit about the story, because how this came about is really pretty interesting. It started January 6th when with our county public health leaders. And San Diego is a bit unique, kind of like Sacramento, where there is no safety net hospital run by the county like there is in Los Angeles and San Francisco. In San Diego, the county sold their county hospital to UC San Diego in 1969. So we are the safety net hospital, and we're partnered very closely with the county public health on a number of different efforts. So I was part of this call with our CEO on January 6th when we brainstormed up this crazy idea that we should open a superstation capable of delivering 5,000 or more vaccine doses on a daily basis. And in part because of our kind of lean management system and tiered huddles in the health system, we rapidly committed to this idea. And 5 days later, on Monday, January 11th, we opened the doors to what you see here. And so I'll take you through that in a little bit, but you can imagine some of the heroics that were involved with opening, the infrastructure, the information technology, the processes. We actually had to get the self-scheduling website up by that Friday in order to fill up those slots for Monday. Now, this was a partnership between UC San Diego, the County of San Diego, the City of San Diego, which helped with traffic flow and others, and of course the San Diego Padres, who I'm sorry to say, Eric, will probably beat the Dodgers in the World Series this year. But unfortunately, he's muted. The Padres brought a lot to this partnership because the Padres use this parking lot for their games. And so they had contracts in place that allowed us to open with security, and also the tents that you see. Some of the Wi-Fi is provided actually by the stadium through a direct link. And so a lot of things that would have been barriers to opening in just 5 days were overcome in part because of the Padres partnership. So the flow that we designed works like this. So this is actually from an article we published in JAMA in late January. The QR code's there if you want to see the article. But this is the key image. So people come in on 13th Street, marked in A here, and these are the registration tents. So the registration tents are where scheduling information that's been self-entered by individuals is confirmed. It's also where we confirmed eligibility, which initially was just healthcare workers, and then individuals over 75, and then individuals over 65, and of course now we've opened it up much more broadly. At C are the vaccine tents, and I'm going to talk you through the flow here because it's really interesting both to be a part of the design and to understand how it works. So each one of these tents holds 4 cars. And so you can see in C that there's 12 cars in these 3 tents, and there's actually 12 tents across. So if you do that math, there's about 144, we'll call it 150 cars in a given session. Now they're all moving at a different pace, but we can average it out. The 150 cars, if you turn it over twice an hour, will give you 300 vaccines per hour, or over a course of a 12-hour day, about 3,600 vaccines per day. And in fact, that's about what we did the first week as we were learning how this flow worked. Now, we wanted to meet our commitment of 5,000 a day, and so that required us to reduce that turnover from 30 minutes to about 20 minutes so that we could turn over a whole row of 12 cars within 3 times within an hour. And by doing that, we're now hitting about 450 vaccines an hour, or over the course of a 12-hour day, over 5,000 vaccines a day. And in fact, we hit that by the end of week 2. And at our peak, we vaccinated almost 7,000 individuals a day, partly because we had some cars coming with multiple people to vaccinate. So here I am administering vaccines. I can tell you it was a lot of fun. You know, this was a real shot in the arm of morale for some very tired healthcare workers. And in fact, one of our biggest problems was people who wanted to go volunteer there instead of going to their day job. We obviously couldn't staff this entire site with just UCSD health employees, though. And so within the first week, we had opened up the call for volunteers, initially throughout our university and then throughout the community. We actually got over 25,000 volunteers applying, and we ended up using, I think, about 3,000 of them. So this was just a tremendous experience. Staffing with volunteers is different than staffing with employees, of course. And so some of our lessons learned there were around the electronic health record, which we were using both for scheduling, registration, and documentation of vaccines. So they all flow back into the California Immunization Registry through our local San Diego Immunization Registry currently in the county. The electronic health record, though, was both a gift because it allowed us to open January 6th long before my turn was a thing. But it was also a curse because that meant that anybody who was using the health record for registration, documentation, needed to be trained, needed to be provisioned. And of course, we didn't want to, add 3,000 volunteers to an EHR, for privacy and security reasons. And so by week 2, we developed workflows around scribes. And that scribing workflow turned out to be terrific, because it allowed the vaccinators to do what they do best, which was to get shots in arms. And it allowed our employees, and not just employees with clinical backgrounds, but employees in information technology and quality and patient safety and regulatory and many, many other departments who use the electronic health record today to come volunteer, and they would scribe for the vaccinators, and we'd pair them up, and that workflow just worked really, really well. And in fact, by week 3, we had replaced some workstations on wheels with mobile devices. We're using iPhones and the mobile application so that every individual comes through with a QR code. We scan the code to find the patient. It's about 3 clicks to document. And the vaccinator is focused on getting those 4 shots in arms as quickly as possible, because there's 3 vaccinators per row. And that allows us to get to minimize that time before you start the clock that begins the waiting period, the 15-minute waiting period. Now, I have to tell you, just on a personal note, 15-minute waiting period is some of the most fun, because we're busy sort of giving the shots very quickly when it starts, but during the waiting periods when you get to talk to people and answer their questions. And we've had just phenomenal response from the community. And I can tell you, particularly as we started with many of the elderly patients, there were a lot of tears, a lot of sighs of relief. Just yesterday, we had a 91-year-old opera singer come through, and she actually sang an a cappella opera during her waiting period to everybody in the row of cars and got a standing ovation. So this has been a tremendous, tremendous experience. I think partly as a result of this publication in JAMA, we also ended up sharing our experiences across the country. So we've had a number of reference calls. I just got another one this evening from the Chicago Cubs Stadium, which Aurora Health is running, to Moscone Center with Kaiser, to St. Louis and Barnes & Jewish and their efforts there. So just lots and lots of work. We solicited volunteers all over. Bernie helped us with that. And once again, you can see kind of our data within the University of California. This really helped put the entire UC system on the map through this partnership. Now, one of the challenges we saw with this is that, as we all know, this is biased towards people that have, internet access and the time and, ability to do this. We're putting information on Twitter and other social media channels. We were sometimes criticized for that in the press. I can tell you, we also sometimes saw elderly patients come through who had gotten text messages from their children and sometimes grandchildren saying, "Hey, there's appointments, I made you one," etc. So, it wasn't a perfect system, but it did work to get over 120,000 individuals through. We've given over 200,000 shots as of today. But on the lower left-hand side here, you see the Healthy Places Index score. And HPI is a construct kind of like, Area Deprivation Index, ADI, which is a national construct. But HPI is something used in California where addresses, not just zip codes, but down to real census tract addresses are mapped to a Healthy Places Index. And that lower quartile, of course, is the most challenging group to vaccinate, more likely to be essential workers or perhaps not homed, et cetera. And this is some recent data that we have showing that our PETCO efforts, which again have vaccinated 120,000 people, we're skewed towards the right when it comes to the Healthy Places Index. And so UC San Diego really wanted to get out into the community and help get some of those more disadvantaged areas where unfortunately COVID was actually a higher risk as well. And so we launched a mobile vaccine unit, we call it the vaccine bus. It goes out to different partners in the community and community benefits organizations on a daily basis. We were at the Jackie Robinson YMCA last week, which is where this was taken. And we know from our data just this morning that over 50% of those patients are coming from the lower quartile from an HPI standpoint. So this is really helping us to accomplish our goal of serving the needy at University of California. Another thing that I'll just comment on before I close, I think is really important, is that this graph also shows not only the PETCO, but also the outreach to our patients at UCSD. And while not perfect when mapped against, that county HPI index, you can see here that our patients were much more equitable in terms of outreach than the open to the public kind of approach, that we took at PETCO. I think that's important as we look at the My Turn strategy across the state of California, which has kind of the registration sign up and other things. But again, we know it's going to take outreach into the community to help get these vaccinations into the arms of everybody who needs it. So that's a little bit about the story, and I think I'll stop there and see if I can answer any questions.
Chris, that was awesome. I really appreciate your presentation. I have worked at some of these sites and I know how intricate they are and how many working parts they have. And for you guys to put that together in 5 days is pretty remarkable. So one of the things I noticed every time I worked at a site, it was a little bit different. So for example, the first time I worked, we didn't have that scribe thing. The vaccinator was drawing up their own shot, and we were typing everything in, and it would take like 10 minutes for each person, and then they divided those jobs. So besides the scribes, any other lessons learned, like quality improvement things that you guys did along the way?
Sure. Yeah, and I want to give credit to some of our operational leaders like Will Ford, Lydia Akita, who were really helping us to lean Six Sigma this whole process. So, we did things like visual cues. You have to get all 12 cars in that row vaccinated before you start the 15-minute waiting period, because you can't pull out one of the cars without pulling out the others. And so we would do a visual cue when the last of 4 cars in the tent was vaccinated, and that way we knew when to start the clock more easily. We also knew that we had patients coming in who had had previous vaccination reactions or medication reactions or were otherwise at higher risk. And so one of those rows we ended up dedicating to a 30-minute waiting period. And that was the row where the doc of the day and the EMS folks who were on site would hang out, to help with observation and other things. And we could run EKGs and do some, simple and basic kind of diagnosis in that row as well, which was helpful. I'd say that, the information technology has been a focus, trying to make it as easy as possible for people to sign up. We wanted to do things like remove the requirement for social security numbers, which could be a perceived barrier of entry for, people scheduling vaccine shots. At the same time, we have to meet a bunch of county and state requirements around reporting, right? So anybody in the state of California, except for a federally supplied site, has to report to the state immunization registry. And so, race, ethnicity, and some of these other fields have to go. In fact, now we're negotiating with Blue Shield how we're going to collect employment and comorbidity data that they want to be able to report at the state level. So, a lot of this is about data. We took a lot of data out of the electronic health record for optimization purposes as well. And, I'd say that the biggest single challenge, Eric, and I know everybody has felt this, has been the issues of vaccine supply. So we learned from some of our smaller sites when we were only vaccinating our own healthcare workers that you really can't run Pfizer and Moderna together at the same clinic. And now, of course, we have the Janssen option because you need to make sure that your supply is consistent, that you're documenting consistently, et cetera. And so we run Pfizer days or Moderna days. Now at Petco Superstation, our supply from the county was mostly Moderna based. And so when the weather hit the East Coast, not only did it disrupt the transport of the vaccine, it also disrupted the manufacture of the Moderna factory in the Northeast. And so that really hurt us. And we ended up having to shut down Petco for a few days. And then we were rescheduling thousands and thousands of people, for other appointments. Some of them were bumping up on that CDC recommended 6-week, limit. And so then we were rescheduling other people, even though we had Moderna vaccines, so that we could prioritize the folks that were most overdue, the greatest second dose stat. So lots and lots of lessons learned, and we will be continuing to vaccinate our patients and other members of the public as we move forward, just not at Petco Park.
Yeah, what are you guys doing? Yeah, now that the Padres are kicking you out, what are you guys doing?
So we have another superstation on campus at the university, capable of doing over 5,000 a day. And then we've been in discussions with the county about opening a site at San Diego Convention Center where we could do over 5,000 a day. But we're waiting on that until we know that vaccine supply is more consistent than it's been.
So one of the issues I always saw when I was working at these places is it seemed like half the people who came in for shots had some additional requests, like, I don't want the Pfizer vaccine, or I'm here with my 62-year-old husband who doesn't quite qualify, but he's here, could he get his shot? And at the sites I worked at, they were very, very strict about it. And I'm curious how you guys dealt with those issues. They're very complicated.
Yeah, it is complicated, and it puts, I think, the front line in a very difficult position. And we had a process actually with radios around, dealing with those type of requests. But I can tell you the UC San Diego Health was equally strict about it. You really had to meet criteria in order to be vaccinated, and we did not deviate at all from the state rules. That being said, of course, part of the state rules are that leftover doses, after hours can be distributed, rather than wasted. And so we had a very tight process around that. I'd say that was another one of our QI kind of efforts. When we first started that first week, we would have 60, 70, 80 extra doses because the vaccinators were all drawing up their own syringes. And by week 2 or 3, we had migrated to having somebody draw up all the syringes, and we were doing syringe tracking. And so we could manage it much more tightly, where at the end of the day, we would only have 20 or 30 doses left over. And then we worked with the county. We'd go to, St. Vincent's and work with the homeless population, or we'd work with first responders or others to get that vaccine into the arms of the folks who've been prioritized by state rules.
So you do a lot of IT work, and I thought when this whole thing first rolled out, we were vaccinating like 75-year-olds, but we were having them make appointments online, and this was a purely digital endeavor, which is, worked out for people who have grandchildren and whoever. But were there any efforts that you guys made to allow people who weren't so tech savvy or didn't have access to the internet were able to schedule?
Yeah, absolutely. Yeah, so we knew that was a problem that needed solving. I wouldn't say we've solved it, as you saw from our, HPI data, but I'd say a couple strategies have been helpful. One is that because this was a partnership with San Diego County, they were able to leverage 211. So that's our local community service organization that's, county funded and partnered. And so 211 can actually make appointments for individuals who called there and didn't have internet access or had other issues. So that was one very helpful thing. Obviously we don't have a call center large enough to handle all of the Petco volume, but for our own patients, we did have a strategy of outreach to the patients via automated phone calls and text messages and things like that. And then they could call our call center line to help with appointments as needed as well. And so those have been helpful. And then, as I said, getting out to some of the really challenging, areas with a mobile vaccine unit has been helpful as well. And I think this is a well understood, concept around addressing vaccine hesitancy as well as other challenges is, using local partners and respected church leaders and, local politicians and other things to help promote, the vaccine on site at a convenient location near them.
There's time for one more question. Oh, go ahead.
I was just going to say, the irony is that even though the percentages of Petco Park were skewed towards the right, just because of the sheer volumes, we actually have still served more, in that lower quartile at Petco than we have with our mobile vaccine units so far. I'm sure that will change soon.
So time for one more question, which actually goes to vaccine hesitancy that you talked about. So we are currently in a situation where there's not enough supply for the demand, but it sounds like very rapidly in the next few months, we're going to be in a situation where there'll be enough vaccine for whoever wants it, and we'll open this up to all age groups. Do you guys have any plans for how you're going to, deal with that free-for-all? And then, do you guys have any plans for addressing hesitancy with the community to encourage people to come in and get vaccinated when there's enough for everybody?
Yeah, that's a great question, Eric, and we have started some planning around that. And I can tell you, it's based a bit on the fact that we vaccinated, or we offered vaccinations to 11,000 of our own healthcare workers, and we saw uptake in about 8,500. So really good uptake, but still, some of the areas where we didn't get uptake were areas that were perhaps at the highest risk. And so we worked with union leaders in those areas. We've done direct outreach, town halls, and other things to try to get more adoption within our own employees, right? And so I think it'll be similar strategies with our patients. But I'll tell you, data and some of these, automation workflows that we can put in place with electronic health record will be really key. And so I really want to, highlight on the data side that the California Immunization Registry has record of every single COVID vaccine that's been given. And so we're getting ready to go live with a bi-directional interface because we want to be able to pull that data back for our employees and our patients that have been vaccinated outside of UC San Diego. Even though 1 in 4 San Diegans have received their shot from UCSD, whether as at Petco Park or as a health system or whatnot, we still know there's a lot of people that got it at CVS or Costco or Walmart or elsewhere. And we want to have that information because to be able to target outreach to people that haven't been vaccinated, we need to know who did get vaccinated outside of our organization. So that'll be very soon. Once we have that data integrated in our system, that'll allow us to do better targeted outreach and really phenotype discovery, right? So, what are these groups of patients? What do they have in common? And therefore, how can we put in place interventions to help? And of course, as we return to a new normal, we'll put automation into the electronic health record just like we do with the flu shot every year, right? This patient has not yet received a flu shot or has not yet received a COVID shot or a COVID booster, as it were.
Chris, that was awesome. Thank you so much for everything. 2 quick comments. Number 1 is the Dodgers and the Padres cannot play each other in the World Series. They're both in the National League.
Playoffs.
And then number 2, in the chat, I put the link for Chris's article in JAMA about the implementation. You guys truly were groundbreaking and led the way for the rest of the country. So thank you for everything that you.
It was a real partnership, and Eric, thanks for having me. And go Padres.
And with that, I'm going to toss this over to Dr. Pannaraj, who's going to introduce our next speaker.
Great, thank you so much for that. That was wonderful, amazing work that you've done. I have the pleasure of introducing Meg Dorsey, who is on the board of directors at the California Immunization Coalition, but her day job is as an immunization coordinator for Placer County. There she manages a variety of immunization activities, including provider support, community outreach, education, surveillance, and she has really been put a lot of effort into and successful effort into distributing COVID-19 vaccine there and coordinating efforts with medical centers and schools and pharmacies to vaccinate the population efficiently. So we're very glad that she's here today to speak to us about that.
So thanks also to Dr. Ball and Dr. Pannaraj for inviting me to share my experiences running a COVID mass vaccination clinic. Also, thanks to Dr. Longhurst. It was wonderful to hear your presentation of your efforts in San Diego. I would have to say you are most definitely a big fish, and the comments I'd like to share today would be more from the perspective of a smaller fish. I'm sure that many of us have already chosen our models and have already been rolling along with our mass vaccination efforts. but I hope that my comments today might contain a pearl or two for those of you who are continuously working on process improvements, as we certainly are on a daily basis. So it's really good to hear what other folks have to say as well. Okay, so first I want to acknowledge that while my contribution is running the clinics, I'm part of a core team of 6 that created our model, set up the physical clinics, hired staff, and conducted daily communications and service. My team includes Vanita Heston, who manages the vaccine allocation at the macro level. She also manages all the information, immunization information systems that we use, such as CalVax, CalReady, and we are still using the PrepMod system for an online registration. And she also allocates vaccine to and supports our vaccinating partners. Chris and Beth are the site leads, and they come from our emergency preparedness team. And as I mentioned on my slide, Beth is a musician and Chris is our magician and Chris is our bouncer. Any supplies that you possibly need, anything from a Band-Aid to a new fridge, Beth makes it appear in 15 minutes. And Chris, who I've named the bouncer, he assists in managing our non-clinical staff. He assists with tech issues, but he also rides herd on our disruptors, which we have many disruptors regularly. Our disruptors include anti-vaccination protesters, hecklers that like to intimidate those people that are in line for shots, and also individuals who sneak into our clinic site to film or photograph our clinic operations without permission. And that's a real problem, and Chris gets to live out his alter ego as a bouncer on that. Katie is our public information officer, and in addition to many other things, she posts clear information about all things COVID, including our vaccine clinics each week. We post appointments for our clinics on Friday, usually in the afternoon between 3 and 5. And we are posting about 1,400 appointment slots per week, and they fill up within about 30 minutes. Our routine pattern is we haven't had to cancel any clinics, but we have had supply disruption, as Dr. Longhurst mentioned. We typically put in our allocation Tuesday. We receive notice of our vaccine shipment on Thursday. And so we post our vaccine opportunities on Friday, knowing that we're going to have vaccine in hand. And then lastly, Mike Romero is our emergency preparedness director, and among many other important duties that he has, he's the person who has all the contacts and relationships to mobilize the appropriate eligible population that we're trying to vaccinate. For example, we started our clinics the last week of December, and we began with long-term care workers. And then when it was time for teachers, he reaches out to those populations and basically delivers that group to our clinics. And then for a quick, just a quick overview on our vaccinating partners and our progress. We receive between 5,000 and 12,000 doses each week. And Placer County has a population of 410,000, so that's our typical allocation. And we get a mix of first and second doses. We have several vaccinating partners listed here. The state long-term care facility or state long-term care program, which is conducted by CVS and Walgreens, which is just about concluding right now, as well as the MCEs, receive vaccine directly from CDPH. And in our county of Placer, we do have our two MCEs include Kaiser Health Systems and Sutter Health Systems. And those folks get vaccine directly from CDPH for the most part, but we have supplied Sutter and Kaiser with second doses when they have run short and they are holding clinics and they need additional second doses. The other entities listed here on the slide receive vaccine from us out of our allocation. And these include 8 Safeway sites that have delivered 13,000 doses thus far. We have 1 private pharmacy, Remedy RX, and they do about 500 doses per week. And I appreciate the contact connection there with the CIC. And Placer County thus far has delivered 55,000 doses at our own mass vaccination clinic that I'm going to share more with you in just a moment. And regarding expansion, we are unsure as to how long we will be in the mass vaccination business as more locations, including retail pharmacies, offer more opportunities. But I think we're likely to grow before we shrink as we open up, as I think it was referenced, the free-for-all, as we open up to the general population. I think we'll be in the mass vax clinic business for quite some time. So how do we plan to ramp up? Well, we plan to we're discussing three possible options, either adding additional sites. We currently only have one site in Roseville, which is our population center. We can add additional shifts to our existing site. We currently run clinics from 9 a.m. to 3 p.m., but we've explored the possibility of adding a 3 to 7 p.m. Clinic on top of that clinic at our existing site. And also, we're always looking to add more partners, and we continue to do so. We're currently serving 16 and up with healthcare, chronic health conditions. That's kind of where we're at in all the tiers above. So before I move into clinic operations, a quick comment on staffing. And this may differ. There are a lot of similarities between decisions we made about our clinic and those that San Diego made. But we chose to use only paid staff as opposed to volunteers, because we got a little burned in the H1N1 adventure of a decade ago, and we just wanted to assure commitment and accountability of the folks working at our clinics. I was really reluctant for this model at first, but my opinion has decidedly changed on this. We've experienced situations where staff is called off and we've had no-shows, and it really hampers the smooth operation of a high-volume clinic. We really need accountability. So our extra help nurses are either retired nurses or school nurses, and our communicable disease associates who work as scribes, they work as greeters, they register people, they work in crowd control and line control. And then we have social workers that we have pulled from our routine HHS staff on a rotating basis. And we have a contract with American Medical Response to provide an EMT on site each day. Each of our clinics has approximately 45 staff. All right, our first decision that we made when we began our adventure in mass vaccination was to decide on a location. We began our clinics the first week after Christmas, and we began renting Jones Hall from the Placer County Fairgrounds, and we have committed to rent through June. This allows us to keep our operations set up, and we don't have to continually break down and set it up. So that's super helpful. So securing the location was a really good first start. As I mentioned, we serve between 1,100 and 1,400 patients per day, and signs really help avoid confusion and reduce questions. Although we do have 1 or 2 staff members that work the line every day answering questions and making sure people have appointments and give them information about what to expect when they get into the CHOC space. We also have signs along the way that tell them what kind of a wait to expect, kind of like Disneyland, 20 minutes to Splash Mountain. But I honestly think if you offered any of our folks in line, if they wanted a trip on Splash Mountain or a COVID shot, they would opt for the COVID shot. So these are my favorite signs we have outside our building. These are large flashing marquees. And I took this picture on a rainy, stormy day. We've been lucky to have mostly decent weather, but when it's stormy, people are out there in the line and it's pretty nasty. So we encourage them to stay in their car until their appointment time. And it has helped keep people out of the rain. So more signs just emphasizing mostly how important it is to have an appointment before you show up at our shot tables. So the next slides walk you through our actual clinic. We have 2 greeter tables at the front of our building, and we have 6 greeters, 3 per table. And these folks are checking eligibility by age and by occupation. And now we are checking comorbidities, and I'll make a comment on that in a moment. But we also require that you either live or work in Placer County. We don't care which it is, but you have to live or work in Placer County. And we try to strike the right balance between strict adherence to eligibility criteria and some flexibility. This is really tough. We get sob stories all the time. And if we're not busy and someone has an appointment and we can find any way to qualify them as an eligible person, we do so. But we do certainly try to stay as close as possible to the guidelines. On Monday, we began dealing with the eligibility regarding chronic conditions. And while there are very broad guidelines about what that means, how to deal with qualifying people was not really made very clear. So we had this great idea to have people, when you registered online for your appointment, there was a link to print out an attestation form, and people were asked to print out their attestation form and bring it in. But it turns out that nobody noticed that. Very few people actually printed it out and filled it out. So when our clinic started on Monday, we had about 20 or 30 miserable, confusing minutes with people not having attestation, and the whole clinic came to a screeching halt. So we just decided to go with the honor system and just accept a person's statement that they did have one of the eligible chronic conditions. And again, while we try to be strict with the criteria, we're also, our goal is really, we're trying to vaccinate people. So we're just trying to thread that needle. So our clinics are pretty high volume for us. Certainly we're not doing the volume that San Diego is doing, but for us it's pretty high volume and pretty complex. We occasionally have a simple one-dose only clinic with one brand, but usually we are slinging 2 brands a day, both a first dose and a second dose on top of each other. Friday we began with a 3rd brand, and we know there's more to come. So what we decided to do was to have 2 lines, one for each brand. And we put stickers on folks, whether they're getting a Moderna or a Pfizer dose, and whether they're getting a first or a second. And it makes it easy for us to take a look at our line and see, we may know in any clinic that we have 50-50 Moderna Pfizer showing up for that day, but we don't know when they're going to show up. So sometimes we have to flex and change a table that may be shooting Moderna and make that quickly into a table that's shooting Pfizer because the line is full of Pfizer folks. Okay, the one thing that we all hate is when the internet goes down or the PrepMod platform goes down, which happens with undesirable frequency. Then we have to jump to old school clipboards. And this is just a really quick way to have people fill out the contraindication form and their demographics, and we put them through, we vaccinate them on paper, and then as soon as we get internet back, we go ahead and chart them online. All right, so this is a look at our clinic space. It's 11,000 square feet and it has a 30-foot ceiling. It has 3 truck doors that aren't open in this particular picture, but if the weather's not too bad, we open up all 3 truck doors, and that really improves the ventilation. We have 12 tables inside our clinic space, and they are set up for 2 nurses per table. And this is what our tables look like. Just as San Diego decided to go with the Scribe model, we also decided to go with the Scribe model, and this was one of our best decisions ever. The Scribe supports 2 nurses. The Scribe checks the registration, informs the nurse of any screening questions that need attention, such as pregnancy, allergic reaction, or being immunocompromised. Then the Scribe quickly prepares the CDC card and then charts on the patient. This allows for efficiency and accuracy, and it also allows the nurse to have the appropriate conversation and vaccinate the patient, all with eye contact with the patient. Our first dose encounters are scheduled for 3 minutes. So we set up our clinics every 3 minutes for a first dose, and our second dose encounters are scheduled to be a 2-dose encounter. And this may sound really fast, but using the Scribe model, it's really not very rushed at all. The Scribe have boosted efficiency tremendously, and I just want to also mention, we have not transitioned to the My Turn platform. I don't know when and if we will do that, but PrepMod has its challenges, but it's been actually pretty user-friendly as long as it doesn't go down. And we've made friends with the PrepMod software. These are tools of the table. If anyone's shopped at Nordstrom Rack, you know what these flags can do. Whenever a table, a Moderna or a Pfizer table is open and ready for a patient, they wave their little flags, and it makes it easy for the people sorting the line to feed the right patient to the right table. We have a well-equipped triage tent right here. A little quick evidence of our triage tent. We typically have 3 to 4 patients visiting the tent every day. I would have to say we have often we have vasovagal episodes and lots of anxiety, but no actual allergic reactions. My favorite anxiety reaction, though, was a woman who said she heard birds chirping in her ears and was that related to the vaccine. I was happy to tell her that no, it was not. And speaking of observation, we do have an area which is a self-time observation area right here. This is what our observation area looks like. If you do 300 shots per hour, which is what we do, you have to have 75 seats spaced 6 feet apart for your people receiving observation. So that's really our limiting factor. Sometimes we have to slow our shot line down because we don't have any seats available in the observation. And I've been actually surprised that everyone's very compliant with the observation. I thought people might just tromp right out, but they mostly sit around and observe the 15 minutes or 30 minutes if their person identified as having an allergic condition. Our observation area is staffed with a social worker as well as an EMT. And these folks really engage the public, reassure people, answer questions, and I think it really contributes to an overall good experience for our public. All right. And we have an ambulance on site, which I think also gives folks some reassurance. All right, and let's see. Okay, Dr. Longhurst mentioned end of clinic doses. This is a really big challenge for all of us. And of course, our goal is to use all our doses. Once you pop the vial, it's use it or lose it. So we try to have as few doses left at the end of the day as possible. Typically, we'll shut down tables toward the end of the day, and maybe for the last 50 or so people in line, we pull doses per vial. So we'll team up and pull doses out of one vial and pass them out. We call this playing the mother may I game. The nurses come up and they say, may I have 2 doses? And we say, no, you may not, you may have 1. And we really try to keep very few doses out there, but we always do end up with some doses that need arms. We do not allow the public to hang around for extra doses in a Hunger Games fashion. We do have a process by which we reach out to organizations, employers that have eligible patients ready to go. Couple comments on health equity. I know I'm running a little long here. I'll be real quick and finish up. Couple comments on health equity. We post all of our information on our website in English, Spanish, and Russian. Those are our 3 main languages. We partner with the Latino Leadership Council to assist with outreach to the Latino community and assistance with making appointments online. Additionally, the Latino Leadership Council is in touch with large employers in the food and ag industry in our county, and they arrange for employers to send buses of Spanish speakers to our clinics. And here we are with an interpreter preparing a busload of 75 folks to receive their vaccine. Another health equity issue that Dr. Longhurst alluded to was folks that don't have access to internet or literacy with the internet or the registration process. So we also use the 211 to assist with folks that need help. And then lastly, I would say I've done a lot of things in my nursing career. This has been one of the hardest, but it's also been one of the most joyful and gratifying. Serving a grateful public makes it all worthwhile. We receive lots of gratitude, and we are happy to spread kindness, not COVID. So thanks very much for this opportunity to share my experience.
Thank you so much, Meg, for sharing what you have been doing and how it can help others. You mentioned difficulty with hecklers who arrive to the vaccination site and sometimes might try to disrupt vaccine administration. How do you put out messaging when there's so many different media and social media messages that may try to contradict you?
Gosh, well, you know, we do have a small video. We prepared a 3-minute video with just a friendly welcome to your COVID vaccine immunization, and it goes through sort of basics about the vaccine and the safety and so forth. But we don't really post information. We have a pretty active anti-vaccine presence here in Placer County. We're one of those red counties that lights up on the map. So people just know we're there and they just show up. So mostly it's a question of dealing with them on site in the moment. Our bouncer, Chris, is usually pretty good at dealing with them. We have had to call law enforcement on a couple of occasions. But happily, the hecklers, even though they are present, most of the folks that are lined up are grateful when we get rid of the hecklers. They're unpersuaded by any disruptors.
Great. Okay. In the interest of time, just one really quick question. What message do you want providers to know about getting vaccines into their patients? What should they tell their patients, and how can they help the patients get in to see you or other sites that are giving vaccine?
Well, I think access is challenging, and as I mentioned, when we post our clinics, the appointment times disappear very quickly. So we really need to build capacity, especially as we open up to more groups. But I think that For providers, I think it's pretty basic. I mean, I think what you say matters. So providers giving a strong recommendation for the COVID vaccine, saying, I received this vaccine myself, my mother, my family, they've all received this vaccine. So just the basic message that vaccines are safe and effective. We have had some challenges with people demanding this or that vaccine, so it's been kind of reassuring to be well equipped with messages about the vaccines being equivalent, or in the case of Janssen, there's very strong messaging about this vaccine is very effective in preventing disease and death and hospitalization. So we're well prepared with positive messages for folks that show up at our clinics.
Great, excellent. All right, well, thank you so much for speaking to us tonight. Right after the end, I think Cameron might have some end slides for us, but right after the presentation, there will be an evaluation. Please take the evaluation, as it will help us to prepare for future COVID conversations. Let us know what you'd like to hear more about. And that is it for tonight. There will be the next COVID conversations, program number 5 is scheduled for April 14th. Correct me if I'm wrong, Cameron. It's a Wednesday evening, and it will be to discuss kind of grassroots efforts to champion COVID vaccine and to counter misinformation that's out there. So please join us April 14th, Wednesday evening. Thank you very much for your support. Good night.